Good evening to all of you, and congratulations on this great venture of conducting a two-day conference, that too from Muvatura, because it is of particular significance to me. It is my maternal hometown. So while thanking Anno Dental College and Online Dentistry for having extended this invitation to speak, let me introduce my topic. It's called Generational Myths in Dental Practice. Now, this is an unusual name for a presentation. The reason being, I have never heard anyone actually present this topic, but in content, it is essentially about several aspects of medical issues in our dental practices, emergencies, etc. And those are oft-treaded topics. So I just changed the name of the topic and gave a new format to it. Now, you may ask, what is this generational myths? Generational myths are, myths that have been passed down through generations. Every generation has certain myths which are sometimes proved to be which continue to be maintained as realities, and sometimes realities become myths with evidence-based science. Now, I remember something from some years ago when I was doing my BDS, decades ago, in fact. There was this popular feeling that if you gave a bilateral block, it would result in the tongue falling back. I often thought, this is a sensory block. Why should the tongue fall back? But this was one of those generational myths that have been passed down over and over again. And today, we see, even today, there are some people who believe that giving a bilateral inferior alveolar block and a lingual block will actually result in the tongue falling back. Now, this is an example of a generational myth. So what I'm going to talk to you today is about several myths that we carry in our minds and which may or may not be true. Some of them are controversial. Some of them, which have become facts today, may eventually become myths as well. But we are talking about what is happening today. So in a sense, it is what we customarily believe and what is accepted practice. Now, one of the big myths, I wanted to start with this because many of you who are listening to this lecture are dental surgeons because you did not get an admission for medicine, or you thought doing medicine would be more expensive. So it is a second choice for a large number of dentists. It wasn't for me because my father was a dentist and he decided to put me into dentistry. I didn't get into a government college, so he put me into a private college, a good private college like Anur Dental College. And I eventually became a dentist. I've never felt this discrimination between physicians and surgeons. So this is an enduring myth that for some reason, physicians know more than dentists. Now, it is a fact that doctors or physicians know more about their subject. For example, if it's cardiology or neurology or general medicine or whatever it is. But it is also a fact that dentists know more about dentistry. Now, in a given situation, you would find that dentists probably know a little about medical practices because it is part of our curriculum. Basically, we go through basic medical sciences, we go through clinical medicine, clinical surgery, pathology, the paraclinical subjects, and the physicians, on the other hand, know very little about dentistry. So when you encounter a situation of a dental patient with a medical problem, it is very often a dentist can take a decision on his or her own, and sometimes it may be necessary to take a doctor's opinion. So I'm going to try to unravel some of these myths and realities through this lecture, and it is centered on some of the issues, mostly medical issues. While on this topic, we must also address the issue of several general dentists who and specialists who believe that if you're a specialist, you are definitely much better. It isn't the truth, because there is a place for the general dentist and there's a place for the specialist. And in India, the statutory requirements are that if you have gone through a basic dental course, you are competent to practice all areas of dentistry. I've noticed that several specialists object to this, particularly orthodontists, but in the absence of a specialty register, which makes a specialist do only a particular specialty, this is a myth, and dentists can practice all areas of dentistry. This is, I've just highlighted in red the scope of dentistry as per the statutory requirements.
Sir, excuse me, sir. Sir, I'm Dr. Joby, sir. I'm sorry to ask you, sir. Can you please start sharing the slides, sir?
Oh, I'm not sharing the slides, is it?
Yes, sir. But your talk is so much good that we are just enjoying.
Well, I'll just go back. I have a lot of time, so I'll just take you through the thing. So, I'm so sorry. Is that clear?
Yes, sir. Very much, sir. Perfect. Sir.
There isn't much. It's just the things that I've been talking about. So, there is this feeling that, dental surgeons are somehow inferior to a physician. It isn't true in terms of at least knowledge, because a dentist knows as much in his subject as a physician knows in his or her subject. So, this is the format. I'm really sorry about it. Sorry about that. Yeah. It's pretty hot in here. So the scope of dentistry, and as I said earlier, there is this popular myth that dentists can do only a certain spectrum of work, which is not true, because they can actually do the whole spectrum of dentistry, including orthodontics. And I know that Binu is an orthodontist. My daughter is an orthodontist. They all object when I say this, but it happens to be the truth, because what you can see here is what I've highlighted is the statutory provision which says dentists can do everything. So it's a myth to imagine that there are restrictions to what a dentist can do. Now, the only thing that's required is competence, and competence is not defined only by qualification. It's also defined by training. And if you've got training records and if you've got experience doing a procedure, you can do surgery, you can do orthodontics, you can do whatever you wish to. So I'm just trying to bust a few of these myths. Now, while on this topic, I thought I would talk about, when we talked about physicians, now I'm sure that we see a lot of patients who are on anti-platelet drugs, and I'm sure most practicing dentists would have seen patients who come and give you a history of taking antiplatelet drugs. And I hope you know the difference between antiplatelet and anticoagulant. Antiplatelets are aspirin, clopidogrel, etc. Okay, I'm not going to go into the details. Now, many physicians ask you to stop antiplatelets. Now, the reason why they ask you to do it is because they are taught that when you do surgery, if there is bleeding in a closed space, like for example, neurosurgery, it's an intracranial procedure, or if you're doing a procedure in the abdomen or in the thorax, which is a closed space, and if it continues to bleed even slightly, it can result in several complications. But what they do not realize, and that's why I said dentists have a skill set and knowledge set, which is significantly different from what your physician knows about dentistry. So there the bleeding is inside the mouth. You can see the bleeding, and there are several styptics most importantly, pressure, which can stop the bleeding, and there is no danger. So you need to take the risk versus benefit aspect in this issue, and then decide if the risk of stopping antiplatelets is greater than the benefit of not having much bleeding, then you should not take that risk. So, especially in patients who have stents, who have done and had angioplasties and have even drug elucidating stents, which are very thrombotic and can produce thrombotic events, it is best that you don't stop antiplatelets, even if your physician tells you that you can stop it, because a physician is talking about a different scenario. Now, anticoagulants, as I said, is slightly different from antiplatelets in the sense it actually affects the coagulation cascade. And these are given by physicians to maintain an international normalized ratio, which is quite high, and it can cause some amount of bleeding. And you do not want to tamper with the physician's prescription of an anticoagulant drug like warfarin or acetrom, or even the new novel anticoagulant therapy drugs, which if you stop, can result in a rebound thrombotic event. So in those situations, yes, you probably need to consult a physician. But we must also remember that sometimes you have physicians and cardiologists who say stop, or even the dentist may decide to stop these anticoagulants. That is something that you should never do. There is a protocol to do it, and it's beyond the scope of this particular lecture to go into that, but I can answer questions at the end of it if you wish me to. The other myth is adrenaline. I'm sure that every person who is in practice encounters patients who are hypertensives. It's so common, you know? So when a hypertensive patient comes, a lot of physicians again tell you that you should not use adrenaline. This is because, in fact, I have had several conversations and actually treated several physicians who actually believe that you should not use adrenaline if you're a hypertensive. If you're a well-controlled hypertensive, there is absolutely no problem. But even if you're not very well controlled, if you give adrenaline in a dose which does not exceed 0.04 milligrams, which is about 4 ml of local anesthetic with 1 in 100,000 adrenaline, you can do all these procedures. So even if a physician tells you, the reason is by adding adrenaline to your local anesthetic, you potentiate the action of the local anesthetic, cause less pain, and produce less amount of endogenous catecholamines as against not using adrenaline. So when you look at risk versus benefit, there is a benefit in actually using adrenaline, provided you always aspirate and do not give an intravascular injection. The injection is given very slowly so that it does not get absorbed very fast and produce tachycardia, and you do not inject into a hyperemic region. And also you have to be a little careful about using them in patients who are on psychotic drugs like tricyclic antidepressants, even the street drugs. They all potentiate the action of catecholamines, and people who have strokes can, sometimes have a stroke in your chair, so you don't want that kind of situation. So just be cautious about it, as long as you keep within your limits and you are sure about what you're doing, and do not inject into a vessel or into an hyperemic area, and you inject slowly. There's absolutely no contraindication to the use of adrenaline, even if your physician tells you. Diabetes, I don't think you can ever practice without encountering a patient who is a diabetic. India is the diabetes capital of the world, the country with the most number of diabetics. Now, a lot of people believe that extractions or interventions in dentistry should not be done on diabetics. They are scared. I have a lot of people referring cases to me. A well-controlled diabetic can be treated just like anybody else, and the procedure can be done normally, preferably in the morning, after a good breakfast, and after they have taken their drugs, if they are taking drugs. The only problem in diabetics is that if for some reason, because again, physicians tell them, when you go for a procedure, don't eat, because that's conventional in surgical practice, general surgical practice. So if a patient has taken an anti-hyperglycemic or insulin and has not had breakfast, there is a dangerous hypoglycemia that can happen. So that is something that you need to avoid. So diabetes is no contraindication, but if you're doing, and in fact, you can even do INDs and emergency procedures to mitigate the infection, even if the diabetes is uncontrolled, because there again, risk versus benefit needs to be used. But if you're doing an elective procedure, it is always necessary to have a patient under reasonable glycemic control below 200 milligrams per deciliter, or a HbA1c glycosylated levels of sugar, which is below 8%. 7 to 8% would be ideal for a procedure which is elective. Now, this is something that we do, and in fact, we still, I think, follow it in our clinic, is to cover all diabetic patients with antibiotics. Well, evidence says there is no scientific evidence to prove that using antibiotics in any way alters the outcome. If at all you have to use an antibiotic in a patient, the better form of giving an antibiotic would be a mega dose of perioperative antibiotic, maybe 1 to 2 grams, just like you give for infective endocarditis prophylaxis. And some of them follow it up with 2 or 3 doses, but it is not compulsory. It's a myth to believe that all of them should be covered by antibiotics, particularly if they have good glycemic control. Which brings us to antibiotic prophylaxis for joint replacement. Now, joint replacement is something that is quite common today. People have knee and hip joint replacements. And there is a myth that all patients who are going to receive joint replacements need antibiotic prophylaxis if you're doing a dental procedure before that. This, again, is a myth. In fact, the American Dental Association, the transplant protocols, both in Europe as well as in the continent, and perhaps in India, do not require you to do procedures under antibiotic cover. Antibiotics and endocarditis, it's something that we have always been doing. 2 grams of amoxicillin or 600 milligrams of clindamycin are often given for patients with cardiac problems with a high risk of infective endocarditis. Now, the question that we have to ask is, who are the patients who are at high risk for infective endocarditis? For some reason, a lot of cardiologists, again, would ask you to use prophylaxis, endocarditis prophylaxis for all patients with a CABG, with stents, with ischemic heart disease, mitral valve prolapse, etc. Those are conditions which do not require them. In fact, one of the highest risk for endocarditis is in patients who have had a previous episode of infective endocarditis. And definitely the patients with valve replacements require prophylaxis for endocarditis, and congenital heart disease and cardiac transplants, which are becoming more and more common today. They do require prophylaxis for infective endocarditis. An enduring myth is that local anesthetics cause anaphylaxis. We've been hearing this and for several decades, and most physicians would swear that they have come across a case of local anesthetic induced anaphylaxis. And virtually no dentist would have actually come across this, although dentists are the biggest users of local anesthetics, with or without adrenal. Now, the local anesthetic, the reason why people believe that there might be an anaphylaxis is probably syncopes are mistaken for anaphylaxis. The other reason is, in the old days, people used non-disposable needles, and the same needles were used for penicillin and then again used for giving local anesthesia. That might be the reason why it is generationally carried on. And the other is some of the ingredients like the antifungals and the preservatives, and all of them are removed now. The new set of local anesthetics are absolutely non-allergic and it's absolutely safe. And don't let anybody tell you that you can get an allergic reaction with local anesthetics. Impacted teeth. I'm a maxillofacial surgeon and my bread and butter comes from removing impacted teeth and doing dental surgery. But I must tell you that there is an over treatment for impacted teeth, especially in the cities. The moment they see an impacted teeth, they would say it has to be removed. Now, all impacted teeth do not have to be removed. The reason people give for removing impacted teeth is one is that it forms a weak point at which a mandible can fracture. But what we must remember is that if you have a force on your jaw, the mandible will fracture somewhere. And it's better it fractures at the angle than it fractures at the condyle, which will be more difficult to treat. The other is that they can form into cysts. Now that is like saying that because you can get appendicitis, we must all remove our appendix. An appendectomy must be done for everybody because there's a possibility of an appendicitis. So there is no rationale in removing impacted teeth. They remove it for various reasons. Orthodontics, several orthodontists tell me that there isn't a necessity for removing impacted teeth. Of course, nowadays when they use stat screws and make arch movements posteriorly and things like that, I suppose it's justified, but generally not required. The other reason is anybody who's had an OPG and impacted teeth are seen are advised to remove impacted teeth. So that's a myth that impacted teeth have some kind of a deleterious effect on your health. It doesn't. So unless specifically indicated due to pericornitis and recurrent problems, do not remove impacted teeth. It can cause more problems. By removing impacted teeth, like you see in this picture here, you can actually expose the root of the tooth in the front and actually cause more problems for the adjacent teeth as well. And also neurosensory disturbances. And so you always weigh your risk versus benefit. X-rays in pregnant women. Now, before I just come to X-rays, there is this enduring myth again that pregnant women should not have extractions. But today, most gynecologists readily clear them for an extraction. But there is absolutely no contraindication for extraction in pregnant women, even in the first trimester. X-rays, well, the old X-rays, they produce a lot of radiation, but the newer generation of X-rays have very little radiation, and it isn't really required, even in the first trimester, to avoid X-rays. But if you want to be really cautious, you can use a lead apron, and it would make both the patient and you quite comfortable in doing the procedure. Now, in this context, I also need to tell you that orthopantomographs the newer versions have less amount of radiation, but they should be used with caution. And CT scans definitely, because all CT scan centers would definitely ask the question on whether somebody is pregnant or not. So those have very large doses of radiation, and it should be avoided. Which naturally brings us to the next imaging technique, that's the MRI. So MRI is preferred in pregnant women because of the reason that it doesn't have radiation. But there's another problem which many dentists think about. A lot of patients have fillings, crowns, bridges, and many of them are made from ferromagnetic materials. And there is this myth that all these will come flying out in an environment which is heavily magnetized. I mean, there's a lot of magnetic forces in the environment in which the MRI is being done. So this is again a myth. But however, ferromagnetic materials will produce artifacts. Those are distortions that are produced and may interfere with making a diagnosis, particularly if it's in the area where the fillings and the metals are, ferromagnetic metals are. Today, of course, you have a lot of materials which are MRI friendly, so you really don't have to worry about those. This is a statement of a study made, because this is a new issue which we've come across in the last decade. Many patients are going in for MRIs, and there is concern about dental metallurgy in the mouth. There are some legal myths. For example, you cannot leave a root behind. I hear a lot of dentists saying that this patient has a problem because the dentist who treated this patient, created a problem because they left a root behind. There is no legal problem with leaving a root stump behind. Now, if you cannot remove a root stump, or if by removing the root stump, you are likely to cause further damage, say to a neurosensory damage, or you can push a root into the antrum, it is perfectly all right legally to leave the root stump behind, even if it's a full root stump. But the important thing is that you need to inform your patient that a root stump is left behind. And you need to tell them that if it causes a problem, you may need a referral or you may need a second procedure. As long as you do that, there is no legal bar on leaving a root stump behind, and something good to know. And today, with the COVID infection, for the last 2 years, we've been battling COVID, and all of you perhaps were at some point of time or the other afraid of the dental aerosol and the possibility of becoming infected with COVID. Now, let me tell you, a dental aerosol is an aerosol that's produced from a machine, from your handpiece or your scaler, and it has no virus. It has other bacteria. There have been concerns about dental, the water used in dentistry, sprays that come out of dentistry. It includes mycobacterium and other bacteria which can technically cause infection to the dentist or the patient and things like that. That's why we have traditionally worn masks. But the coronavirus is not going to be found in your booster, and that water which comes out does not contain the virus. The real aerosol which everybody is talking about is the biological aerosol that comes from your lungs and your respiratory system. So we need to make this clear distinction and take away the fear of dental aerosols being cause for COVID spread. In fact, everybody talks about it, not only dentists, but even the others have now been made to believe that this is a big danger. In fact, in May 2020, there was this publication which actually talked about dental aerosols and the danger of infecting people with dental aerosols. But by August of 2020, we had a clear article in the Lancet written by Epstein, Cho, and Matthias, which clearly said that not only are dental aerosols safe, dental aerosols might in fact be protective. So that is something that we need to take into account and dispel the myth that dental aerosols are deadly spreaders of the SARS-CoV-2 virus. The fact is, it isn't. And dentistry was generally, people were very scared about dentistry, going to dental clinics. And I think you need to dispel that fear, because I think dentists have habitually worn masks over the years and over the decades, and they are probably the best prepared people in this, among the health professionals. And the 2 years have taught us that very, very few cases have been reported in dental clinics. And there's actually been no case or no cluster which has originated in a dental clinic. And this is something that we need to put confidence into the patient, as well as have confidence amongst ourselves to make ourselves believe that we are safe in our dental clinics. And if dentists have had COVID infections, it's something that they caught in the social environment. If there are any questions, it's a short presentation, and I would be happy to take questions through a moderator or directly from the chat box or whatever it is, preferably through a moderator, if you have any questions.